Hello, class, and hello, Dr. Yeager. My name is Marnie Ballesteros, and today I will be presenting my case study of Mr. Smith. Welcome to my presentation, and please excuse the audio. Mr. Smith is a 67-year-old male with no significant medical history. He has a family history of heart disease. His brother and father both experienced cardiac disease that required surgical intervention under the age of 50. He is married, has two grown children, and he is close to retirement. He goes yearly for a physical, gets the annual flu shot, and has the pneumococcal vaccine 3 years ago. He is up to date with his tetanus toxoid vaccine. He received his last one 2 years ago. Mr. Smith had become increasingly short of breath over 1 week, positive for productive cough, and feels fatigued. During lunch with his wife, he develops chest pain and nausea, feels nervous, and asks his wife to take him to the clinic. At the clinic, the EKG showed ST elevation. He is sent to the emergency department for further eval. The focus of this case study will be on myocardial infarction. MI, or heart attack, is associated with coronary artery disease. MI occurs when there is a partial or complete blockage of one or more of the coronary arteries supplying oxygen to the heart muscle. Risk factors contributing to coronary artery disease are abnormal lipid profile, smoking, hypertension, abdominal obesity, diabetes, stress, sedentary lifestyle, or advanced age, as well as family history of premature coronary heart disease. The pathogenesis: when an atherosclerotic plaque ruptures within one or more coronary arteries, it can occlude the blood flow, causing the heart muscle wall to become ischemic, and if prolonged, tissues of the myocardium may become necrotic. Clinical manifestations are of chest pain, upper extremity pain, mandibular or epigastric discomfort that occurs at rest or with exertion, pressure or feeling of heaviness on the chest, radiating pain to the left neck or shoulder. They may look sweaty, get nauseous, display dyspnea, or they could be asymptomatic. Treatment for acute management would be relief of the pain, breathlessness, and anxiety. So they may be given morphine IV, oxygen therapy to keep O2 sats above 90%, nitrates, beta blockers, aspirin, anxiety medication for patients who are anxious, and percutaneous coronary intervention and reperfusion therapy, which is indicated in all patients with symptoms of ischemia if less than 12 hours duration and the EKG shows persistent ST elevation. The long-term treatment would be lipid-lowering agents, aspirin, ACE inhibitors, beta blockers, that's for patients with left ventricular ejection fraction less than 40% unless otherwise contraindicated, antihypertensive therapy, lifestyle management, stress reduction, smoking cessation, and weight management. In summary, we have discussed briefly etiology, pathogenesis, and clinical treatment. Most importantly is the nursing consideration for those who have sustained a cardiac event, such as Mr. Smith had in this case study. It's important to recognize and respond to the patient's fear, anxiety, and address questions that may or may not be able to articulate. Beyond clinical interventions, nurses play a special role in understanding and addressing the emotional and psychological impact that heart attacks may have on the patient and their families, providing professional and compassionate care aids in providing or improving recovery outcomes. Excuse me. References. Thank you for your time and attention.